It is now my pleasure to introduce Dr. Rajeev Sharma, who is a transplant surgeon at Wayne Health DMC Harper University Hospital in Detroit, Michigan. He completed his ASTS Transplant Surgery Fellowship at Northwestern University, Chicago, and a Pediatric Transplant Surgery Fellowship at Children's Hospital of Pittsburgh of UPMC in Pittsburgh, Pennsylvania. He has been a tenure-track assistant professor for transplant surgery at University at Buffalo in Buffalo, New York, director of kidney and pancreas transplant programs at Penn State Hershey Medical Center in Hershey, PA, and an associate professor of surgery at University of Nevada, Las Vegas, Nevada. His surgical philosophy is centered on delivering best possible care and achieving best possible outcomes for transplant recipients and their families. Dr. Sharma is well published and has been a recipient of research funding for investigator-initiated studies and clinical trials. His clinical research interest is focused on novel diagnostics and therapeutics for antibody-mediated rejection and kidney transplant. His translational research interest is focused on BK virus-specific cell-mediated immune response and immune surveillance in kidney transplant recipients. Please join me in welcoming Dr. Sharma.
Thank you, Ellen. Thank you, Chris and One Lambda, for inviting me to give this talk today. The title of my presentation is Clinical Utility of MMDx, Diagnosing Early Antibody-Mediated Rejection. As a disclaimer, the views and opinions expressed in this presentation are mine and do not reflect the official policy or position of One Lambda or any division of Thermo Fisher Scientific. This publication is available on the journal website, and no grant funding was received for the preparation of this publication. So today I'm going to be presenting two cases of early antibody-mediated rejection that were diagnosed with the help of donor-derived cell-free DNA and MMDx, and this is the experience that was recently published. I would also like to share our unpublished experience with MMDx, its concordance with pathology, and utility of MMDx and AKI in the post-transplant setting. We are using commercially available MMDx testing as a part of our standard of care for second opinion on all our indication biopsies. So as all of you know, antibody-mediated rejection is the predominant cause for late allograft loss after kidney transplant, and that there is no FDA-approved treatment for this condition as yet. The standard of care treatment based on expert consensus includes glucocorticoids, IVIG, and plasma exchange, with or without rituximab or bortezomib. But the failure rates are very high. So Redfield et al., they published that there was a 55% rate of 2 years graft survival for patients with chronic active ABMR treated with standard of care treatment, while 20% for those who received no treatment. I'm going to concentrate on the clinical phenotypes. So the two commonly recognized clinical phenotypes are acute and chronic. Where acute generally occurs early, more responsive to treatment, while chronic occurs late and is not very responsive to treatment. The salient differences between acute and chronic are listed in this table on the right. Then there is the Banff classification that has been constantly evolving since it was first introduced, with the most recent changes applied in 2019. This is a busy slide just to demonstrate the updates to 2019 Banff classification. So our understanding of antibody-mediated rejection has been constantly evolving. Once considered an isolated incident occurring after kidney transplant at a point in time, it is now recognized to be a progressive condition that waxes and wanes over time and ultimately may lead to chronic allograft damage and allograft loss. So if it can be diagnosed early, before it has caused significant allograft injury, this could revolutionize the treatment of kidney transplant patients with antibody-mediated rejection, since early treatment will probably result in better long-term allograft survival. MMDx is a central biopsy diagnostic system that uses microarrays to measure mRNA changes with high precision and compare the results to a large reference set using ensembles of up to 100 predefined machine learning-derived algorithms or classifiers. It interprets the rejection and injury-related transcripts in a biopsy. Halloran et al., they used a discovery set, validation set approach of prospectively collected biopsies to document the rejection-associated transcript changes that are either universal, TCMR selective, or ABMR selective. And this table here represents the top 30 mRNA transcripts associated with these archetypes. So coming to the patients, our first patient was a 50-year-old female who received a deceased donor renal transplant for end-stage renal disease secondary to PKD. Her CPRA was 81. She was on hemodialysis for 5 years and was anuric. Donor was a 50-year-old male with a KDPI of 74%. Terminal creatinine was 0.98. Donor had hypertension for over 10 years. No allograft biopsy, so no donor biopsy was available. The pump numbers were marginal. Her past history was significant for cervical cancer, chronic diarrhea, GI bleed, and multiple prior STDs. She was status post-radical hysterectomy with pelvic irradiation. She had a frozen pelvis and calcified iliacs. But the surgery was uneventful. She developed delayed graft function, though. She received induction with basiliximab and methylprednisolone and maintenance with MMF, tacrolimus, and prednisone. Due to chronic diarrhea, she could only tolerate low-dose MMF. She achieved a baseline serum creatinine of 1.1 at about 2.5 months post-op. The baseline donor-derived cell-free DNA at 1 month was 0.41%. The immunosuppression had to be reduced a few times due to bacteremia secondary to recurrent UTIs. The tacrolimus levels were subtherapeutic off and on. As you can see in this slide, the creatinine levels have been pretty steady throughout the course, but the tacrolimus levels were all over the place. There was no donor-specific antibody. At 11 months post-transplant, donor-derived cell-free DNA came back as 1.3%. The serum creatinine was still close to baseline, though. This prompted an indication biopsy due to the elevated donor-derived cell-free DNA. There was mild lymphocytic tubulitis limited to the areas of interstitial fibrosis, and there was a single glomerulus with focal mesangiolisis, which was a finding of undetermined significance. MMDx reported early antibody-mediated rejection. This created a therapeutic dilemma for us since it was the first time that we had encountered such a clinical situation. So we had a long discussion with the patient, and after patient consent, we decided to treat this early antibody-mediated rejection with IVIG. The creatinine levels remained stable throughout the course, and 1 month following treatment completion, the donor-derived cell-free DNA came down to 0.63%. Here is the patient's allograft biopsy. There was no tubulointerstitial inflammation, no endothelitis. Here is the MMDx showing the R4 archetype, which is early antibody-mediated rejection. The second patient was a 30-year-old female who received a deceased donor renal transplant for end-stage renal disease secondary to chronic GN. Her CPRA was 0. She was on peritoneal dialysis for 3 years. She received a perfect donor kidney with a 20-year-old male donor, KDPI of 9%, terminal creatinine of 0.9. Her post-transplant course was uncomplicated, and she achieved a baseline serum creatinine of 1 at about 1 month post-transplant. She received induction immunosuppression with basiliximab and methylprednisolone and maintenance with MMF, tacrolimus, and prednisone. The tacrolimus levels were mostly therapeutic. There was no DSA. For this patient, the first donor-derived cell-free DNA was only done at 11 months post-transplant, and that was 1.6%. We did not have a baseline for her. Because the patient's serum creatinine was still normal, we decided to wait on it for another month and repeat the donor-derived cell-free DNA. The repeat value came back as 3.9%. These are the serum creatinine and tacrolimus levels over the 1-year course. You can see the creatinine is very steady, very stable. The tacrolimus levels were mostly therapeutic. So this prompted an allograft biopsy. The biopsy demonstrated borderline acute TCMR along with the PTC1. There was occasional mild lymphocytic tubulitis, and the interstitium demonstrated mild lymphoplasmacytic inflammation in the unscarred cortex. It did not meet the BAMF criteria for antibody-mediated rejection. There was no DSA. There was no C4D. MMDx reported early antibody-mediated rejection, but no TCMR. So we treated the patient with methylprednisolone for the TCMR, borderline TCMR on the biopsy, and IVIG for the early antibody-mediated rejection on the MMDx. Serum creatinine remained stable throughout the treatment course. 1 month following treatment completion, the donor-derived cell-free DNA came down to 1.6%. And at last follow-up, the donor-derived cell-free DNA was less than 1. Here is the allograft biopsy showing interstitial inflammation, tubulitis, peritubular capillaritis, no glomerulitis, no endothelitis. Here is the MMDx showing the R4 archetype, which is early antibody-mediated rejection. Now, third case is a patient where I would like to highlight the utility of MMDx in AKI in post-transplant setting. So this was a 63-year-old gentleman with end-stage renal disease secondary to diabetes and hypertension who had been on dialysis for 8 years. He was status post radical prostatectomy with bilateral lymphadenectomy for prostate cancer. He had been anuric for 8 years. His CPRA was 0. He received a deceased donor renal transplant from a 44-year-old donor with a KDPI of 70% and a terminal creatinine of almost 5. The surgery was very difficult due to the bladder reconstruction part, since the bladder, due to the ureteroneocystostomy, since the bladder was extremely small and had a capacity of less than 50 ml. The post-transplant course was complicated by delayed graft function, but the patient achieved baseline creatinine of 1.1 about 3 months post-transplant. Baseline donor-derived cell-free DNA at 1 month post-transplant was 0.3%. At 4 months post-transplant, he developed BK virus nephropathy, for which we switched him from tacrolimus to cyclosporin. MMF dose had to be reduced by 50%. After making these changes, he continued to have low-level BK viremia for about 7 months and only cleared BK virus at about 10 months post-transplant. There was no DSA, but the patient had been on reduced immunosuppression for a long time. The creatinine progressively increased from 1.1 to 2.1 during this time. And the donor-derived cell-free DNA at 10 months, when the creatinine was 2, was still 0.15%. About a month after BK virus clearance, there was a sudden bump in creatinine to 9.4 from 2.1. This was exactly 1 month following BK virus clearance. This was a perfect setup for rejection. The patient had been on low immunosuppression, and we were, pretty confused as what to do with this high creatinine. A biopsy was done. Donor-derived cell-free DNA was done, which is normal. It was still 1.16%. Urine output was good. The ultrasound was normal. Kidney had great flow. This is the trend of the serum creatinine and the cyclosporin and the tacrolimus levels on this patient. You can appreciate that sudden bump in creatinine from 2 to 9.4. The cyclosporin levels were maintained between 150 to 200 because of the BK virus nephropathy. So the allograft biopsy was done, which only showed tubular injury. There was no evidence of rejection. There was no associated glomerular activity. MMDx was also sent on this biopsy, and there was no ABMR, no TCMR, but moderate to severe injury scores. Here is the biopsy showing the tubular injury. And here is the MMDx showing the R1 archetype, which is a non-rejecting archetype. So the diagnosis in this patient was AKI secondary to dehydration. So what had actually happened was he had ultra-small capacity bladder that could only hold urine for about 60 to 90 minutes, even at 1 year post-transplant. The more he drank, the more he urinated, so he started drinking less. And for 3 weeks preceding the event, he was only drinking about 1 liter of fluids every day, and he was still making 2.5 to 3 liters of urine every day. So this led to the AKI. All we did was inpatient IV hydration, and the serum creatinine came back to the baseline of 1.2 within a week, which was better than the 2.1 after BK clearance. So in cases like this, we have found it very useful to have the second opinion of MMDx in addition to the biopsy. Because when there is a perfect setup for rejection to take place and you have a creatinine bump like that, and the biopsy does not show rejection, then it's a difficult decision to make to not treat the patient. MMDx in such situations, at least for us, has proved very helpful as a second opinion. So in conclusion, the histologic assessment of biopsies has its limitations because of the subjective nature of reporting by pathologists and limited reproducibility between observers. While MMDx can assess the T-cell mediated rejection and antibody-mediated rejection in a reference set of biopsy samples using machine learning-derived classifier algorithms. Molecular interpretation offers as an objective second opinion that adds to local histology findings, thereby increasing clinician confidence with diagnosis and treatment planning. So this is essentially the reason that we have been using MMDx on every single biopsy that we do. Scheduled surveillance with donor-derived cell-free DNA and molecular assessment of biopsy with MMDx have made it possible to diagnose a new phenotype, which is early antibody-mediated rejection. This could potentially revolutionize the kidney transplant landscape by enabling early diagnosis and successful treatment of the commonest cause of late kidney allograft failure, thereby prolonging allograft survival. Thank you for your attention.